Okay. So this is being recorded because we will share the link to the recording to the entire group of invitees after the event, so that if any of your staff couldn't attend this, or if you need to reference it in the future, you can access it that way. So you'll be getting that from us within the next week, I would say. All right. And so with that, again, I'm just kind of some housekeeping notes. Please remain muted unless you have a question. If you do have a question during this whole presentation, you have multiple ways to ask. You can feel free to pop your question in the chat box during the presentation. You can also raise your virtual hand and we'll try and monitor that, and we can answer your question in real time. We will also have time at the end slated for question and answer as well. So you can ask your question in any number of ways. So first, would like to start by introducing the team that we have on the call today. We have Tracy Hart, Ian Francis, and Heather Petrie. They are, I think, probably pretty known faces to you. They are the Practice Transformation Specialist team here at North Country Initiative and Fort Drum Regional Health Planning Organization. They'll be joining me in presenting, and I'm Joanna Loomis. I'm the Deputy Director here at North Country Initiative. So without further ado, we will go ahead and get started. Thanks for joining today. We are going to go over the HRSA grant that Fort Drum Regional Health Planning Organization has recently received. We're going to go over the basics. We'll get into the project details. So there's 4 goals that we'll dive into in more depth. We'll talk about immediate next steps for us and for our partners. And then we will, like I said, open it up to question and answer. So with that, I will turn it over to Heather.
So we're going to cover a lot of acronyms today. You'll see some of these listed. We're going to drop this into the chat, so that way when we refer to them, if it's not something that's familiar, you'll find it here. So we will drop that right into the chat box so you guys can use that for reference. And we will be sending the slides out after as well. So let's go over the basics. This grant will run from July 2023 till June 2027. The funds are going to flow to partners, provisions of MTCM and MCCM, 4 goals, which Joanna will be touching on in just a little bit. And we're going to show you the list of partners that are going to be participating in the MTCM and MCCM. Next slide, Joanna. Thank you. So you'll see that there are really 2 groups of partners here. You'll see the clinical and primary care and/or behavioral health providers, and then you'll also see community-based organizations. The clinical and behavioral health providers will really be involved with sending referrals out to the CBOs and the other community-based organizations. Once those are received, the social care referrals will be followed up, of course, by the primary care providers. And there'll be hopefully a coordination between the 2. So all partners except for the one with the asterisks have already signed the memorandum of understanding to participate in this grant. But a template of the MOU was included in the email that we sent out. But if anyone needs that resent, just let us know and we'll be happy to send it out to you.
Thank you, Heather. So now we're going to go into some more detail on the goals. Here is the overview of the 4 goals of the project. We'll get into more detail with goals 1, 2, and 3 during this presentation. Goal 4, however, is fairly straightforward, so we don't really need to spend much time on it. It basically indicates that our network will be active in at least 3 value-based contracts by the end of year 4 of the grant. As many of you are aware, our group is already active in a total of 3 value-based contracts currently. We expect that to continue throughout the grant. There could be the possibility of adding additional contracts even by the end of the grant period. This doesn't mean that 100% of the grant partners have to be active in all 3 contracts, but rather just that there's meaningful participation among our group members in a total of 3 contracts. All right, so the first goal is to improve access to transitional care management and chronic care management. And there is an overarching kind of measurable goal for this, which is that payer billable TCM and CCM services will increase by at least 10% by the end of year 4. So this really refers to your billable TCM and CCM services. That is virtually all payers except Medicaid, because Medicaid does not reimburse for these services. Our group has made significant progress over the years in increasing the provision of TCM and CCM. TCM reimburses really well, and CCM reimbursement, while much less in comparison to TCM, can accumulatively generate significant reimbursement, just given the number of patients eligible for CCM and because CCM can be performed as often as monthly. So just thinking about the why, again, certainly good patient care, definitely in alignment with patient-centered medical home certification, which some of you on the call have that certification because you're primary care. Definitely a significant source of reimbursement. TCM billing alone within our Medicare Accountable Care Organization has increased from a total of $19,000 back in 2015 to over $200,000 as a group in 2020 and thereafter. And we have definitely seen in our ACO that TCM and CCM have significant measurable reductions in healthcare costs and potentially preventable events, such as obviously hospital events as well as emergency department visits. But despite this group's progress, there's still room for improvement among most of our partners. We do acknowledge that a few partners would argue that you have maximized your TCM and/or your CCM achievement. You know who you are. We know who you are. The goal is not to push each partner to improve by 10%, but really the whole group by 10%. So that is going to mean that some high achieving partners' performance stays relatively stable, whereas it will require other partners to improve more than 10%. So that's really the why behind this. Again, how can we further push the envelope in really capturing all available transitional and chronic care management services in the region? How do we do this? We're going to build upon the infrastructure that we've kind of built over the years. And what we'd like to do is work with our partners to institute all payer TCM alerting. So a few of you have already started this. It's Loudville Medical Associates, Credo Community Center, the Children's Home of Jefferson County, and Transitional Living. But most of our partners, the rest have not. So what are all payer TCM alerts? Really, it's applying the alerting infrastructure that we use with our ACO and our IPA patients to all of your other patients as well. And I'm going to skip ahead to the next slide just so you can kind of see what we're talking about here. So this is an example of an alert that was recently sent just within the last week to one of our partners. It's redacted, obviously. So we use the Healthy Connections, the Health Information Exchange alerts, but we kind of put them through a second layer of process that we feel, and we've heard from partners, does augment and enhance your ability to perform transitional care management with your patients. So, unlike the HIE Alerts Digest, which is fairly lengthy and includes all admissions, discharges, and transfers for all of your patients, the alerts that we send reduce those down to what we believe are the actionable alerts, the actual patients who are in need of transitional care management now. So we're calling out who, at the top of the page, who's recently been discharged from a hospital setting, and then at the bottom, who's been recently discharged from an emergency department setting. including when they were discharged, which facility they were discharged from, what was their length of stay, the visit reason if supplied, and then how many ED and or inpatient visits have they had over the last 12 months, which can also give you a really quick glance of the sort of level of complication of the patient and sort of, are they a high utilizer? Are they in need of other services in conjunction with a transitional care management like chronic care management? So going back to this slide, we will again work with you to institute all payer alerting. The reason being, over the years, we've focused very much on the Medicare patients in the ACO and the Medicaid patients in our IPA to conduct TCM and MTCM. You've on your own been getting alerts for your commercial and Medicare Advantage and other patients. The thought is that using the alerts that we create could help further augment your efforts in providing TCM to those populations as well. So we will work with you to provide these alerts to you. Those of you who are in the ACO and or the IPA will continue to receive separate ACO and IPA alerts for your attributed patients in those contracts. And you would then receive a separate alert for all of your other patients. After this meeting, we will provide your points of contact with a roster template, which is a simple Excel spreadsheet that will allow us to ingest your roster of patients that we would then feed to Healthy Connections to get those alerts generated for you. We'll also provide you with what we call an order form, which is really just a way for you to tell us who do you want to get the alerts, how often. For example, you can get them real time throughout the day. You could get them batched as a single daily alert, and there's other preferences that you can choose. Order form sometimes means money. There's no money involved in this. We're certainly not charging for this service. So I just want to make that very clear. And so we'll work with you on going to update your patient roster each quarter. The second piece for the how here is chronic care management opportunity lists. So here's where we would work with your team to pull reports from your EHR to identify who from your entire patient panel would be a good CCM candidate. We can work with you to update that list every quarter. For those of you who are in our ACO and or our IPA and who have limited chronic care management resources, we certainly encourage you to lean on those chase lists sort of primarily. But certainly the goal here is how can we maximize chronic care management provision to all patients and all payers. And then part of this is also, as you see how the measure is structured, we're measuring an improvement from baseline. So we will need to gather baseline data. So this will result in two percentages, a baseline for TCM and a baseline for CCM. For TCM, how many TCM services were successfully billed out of how many inpatient discharges? And then for CCM, how many CCM services were successfully billed out of how many CCM eligible patients? We'll work with each of you to measure this for your patient population. We do have baseline data, certainly for your patients in the ACO or the IPA, but we'll need to work together to measure TCM and CCM completion for your entire panel through your EMRs. We will be able to track the TCM denominators via our alerting infrastructure. And kind of the final piece here with the how is social determinant of health screening, coding, and referrals. So most of you in our IPA have already attested to incorporating a standardized SDH screening tool, along with conducting coding and referrals for patients when they screen positive for social needs. And specifically, you're doing that in the context of Medicaid transitional care management. If you haven't, and Tracy will get into this in the next few slides, but if you haven't already done that, we will set a deadline for you to do so by September 30th. And then really looking to our partners to apply that same social determinant screening, coding, and referral process to other patients as well who are getting TCMs and CCMs, not just Medicaid patients. So the goal here, one sub goal here, is to increase the percentage of the target population, so people who are eligible for transitional and or chronic care management, who have been screened for social determinant needs. We want to increase that by 40% from baseline by the end of year 4. That means the intention, again, is for partners to start performing SDH screens during TCM and CCM encounters, not just the Medicaid ones, and to document screens in a trackable way. Some of you have already begun using the SDH screening tool more widely than just during those Medicaid TCM encounters. For others, this will be a new process. I would say that this is absolutely the direction that Medicare, the federal government, state government is moving in. So the faster that our partners can get used to doing this process, the better. It will only help you, not just with this grant, but it's really much more about a bigger picture about where healthcare is heading in terms of social determinant of health incorporation. However, because there's no standardized billing code for conducting a social determinant of health screen, we'll have to work with your organizations to determine how best to track this. Ideally, we could come up as a group with a single standardized way. For instance, using like a sort of a proxy code that you would all use in your EHRs that doesn't, to a payer, means nothing, but we could still run reports off of it to see the volume of SDH screening codes. But we know that some of your EHRs are capable of tracking this as is. So the goal here is to find what's going to work for each of your organizations, knowing it might not be exactly the same. Another piece is that FDR-HPO will update our social services inventory, and we'll send that to partners by September 30th. So that will be just a listing of available known social care resources within the region that you can use to refer patients to when they do screen positive for one or more needs. And finally, we do have standing meetings with each of your organizations at least quarterly. So we planned on using a portion of those meetings to discuss the HRSA grant progress, unless your team would like a separate meeting for this, in which case we can talk about that certainly at your next regularly scheduled meeting, or you can reach out to your practice transformation specialist or myself in the meantime. So what are the next steps, the kind of just bringing it back, what do we need to do now? We will send you the roster patient template. We will send you the order form after this call within the next week. And we will ask for those to be returned by August 1st so that we can feed those to the Health Information Exchange. The goal is to get those all payer alerts flowing by the end of September. The second is working with you to pull chronic care management opportunity lists by September 30th. To work with you to measure your baseline TCM and CCM performance by the end of September. And also to make sure, if you haven't already, that you have attested to incorporating a standardized social determinant of health screening tool, doing the coding referrals, and then updating the services inventory, also all by September 30th. And with that, I will turn it over to Tracy to talk about goal number 2.
So goal number 2 is to provide MTCM and MCCM to the Medicaid patients. We would like to achieve at least 12% of all eligible rural Medicaid individuals will hopefully participate in this program by the end of year 4. How are we going to do that? We are going to supply you with the MTCM alerts for your patients that have seen an ER or hospital visit. We will supply the MCCM opportunity list, those patients that are eligible for the CCM, and we'll help you implement the social determinants of health screening, coding, and referral process. And we will supply you, or we will pay you $80 for the MTCMs and $60 for the MCCMs. This goal 2 really uses the same infrastructure and the processes from goal 1, but the main difference is Medicaid does not reimburse for those services. So with the HRSA grant funding, we will be able to provide these reimbursements to each partner. Through NCI, we have been able to reimburse the IPA partners already for this MTCM service. This grant will not only allow us to continue reimbursing for the MTCM over the next 4 years, but we'll also be able to reimburse partners for the chronic care management for the Medicaid population for the first time. This goal really was built upon a successful pilot program that was led by Complete Family Care, which is an independent practice here in Watertown. In 2021 and 2022, they were funded by NCI's Promise in Practice grant to conduct MCCM pilots with their Medicaid patients. The pilot showed that chronic care management can be successfully implemented with Medicaid population, and it really is resulted in favorable outcomes for care gap closure, reduction in preventable, avoidable readmissions, and completing the social determinants of health screening. FDR-HPO will develop and distribute a fact sheet that gives more details regarding MCCM requirements, which will align with the Medicare CCM fact sheet. First, unlike with CCM, MCCM will require completion of the social determinants of health screening. We will also provide that for you. The other difference is Medicare requires a patient consent to participate in CCM. We will use a presumptuous consent for MCCM. Thus far, partners have utilized a simple Excel spreadsheet to submit the completed MTCMs for us for payment. Given the increase in volume and addition of the MCCM, we will be developing an application that will support billing in a more sophisticated fashion. Until it is rolled out to the partners, we'll use the spreadsheet format now. Partners will provide MTCM by 10/1/23. Many are already doing this. And partners that will provide the MCCM no earlier than 10/1 to rural-only Medicaid patients. Full go live will be January 1st, 2024. So if you are already doing this, great. If not, then we're gonna help you get this going by October 1. HRSA, with rural being said, HRSA does consider, they have their own consideration for rural definition. For our region, all of St. Lawrence County and all of Lewis County are considered rural. Within Jefferson County, there's only a few areas, Alex Bay, Clayton, and Wilna are considered rural. This grant also includes Community Health Center of the North Country, which also serves patients in Franklin County. That is also considered rural. HRSA funds can only be utilized to reimburse partners for MTCM and MCCM services for patients who live in those rural areas. Some of you on the call may predominantly serve rural patients, others predominantly serve non-rural patients, but still have some rural patients in your practice. NCI will propose a budget to its board of directors that includes funding for MTCM and MCCM for non-rural patients. Our goal beginning January 2024 is that patients to be reimbursed for all MTCMs and MCCMs for their Medicaid patients. In the background, Fort Drum Regional Health Planning Organization will be sorting submitted MTCMs and MCCMs by patient's rural status, which would be zip code, and using the HRSA funding to pay for those rural patient services. We anticipate being able to do this seamlessly for all of our partners.
So the third goal in all of this is pretty much to enhance.
Sorry, Ian, you're muted again.
I always do that. Oh well. No one likes to hear my voice anyways. So anyways, goal 3, the overall income is to improve and to close out care gaps for these patients, enhancing the health outcomes. So of these, 35% of the TCM, CCM participants will have the goal is to get them to get their open care gaps closed. One thing we've noticed over time with what we have been doing with MTCMs and working with Medicare patients is a lot of these patients that are utilizing the EDs and urgent cares a lot do have a lot of open care gaps, and they're not using primary care. So part of this process with TCM and CCM is to get these people in so that they can get their care gaps addressed so that they do live a healthier life. We also found out through TCM and CCM, it actually decreases their preventable admissions and preventable readmissions, along with preventable visits to the ED or inpatient care. And the ultimate goal with doing these TCMs is to decrease this amount by 10%. Now, the question is how we are going to do that is, one, we use TCM and CCM encounters to identify and attempt to close patients' care gaps. So by looking at these patients, we do produce care gap rosters. A lot of the practices also get these from the United and Fidelis as well. But we also get these reports and we try to make them useful for them in a way that's easily identify which care gaps are open so that they can address these with the patients. And that's where we get into the care gap chase list that we present. One way we look at which care gaps are closed is we do look and measure the care gap closure via the claims through the IPA ACO. We do look at the EMR reports, ECQMs, and then we also look at PPAs or the possible preventable admissions and possible preventable readmission view claims and ADD fees that we do get through United and Fidelis, along with what we get through claims data. So the next steps is, one, FDR will work with you to pull the care gap chase list. We do get these rosters. We do revamp them some to try and make them as useful as possible so you can identify patients with these care gaps so you can address them. So then what is it we come out to and we actually get down to is, what are we going to do and what are you going to do with the next steps? So overall with FDR HPO is, one, we distribute the patient roster templates to you and the alerting order forms. And these things are really important for you to fill out, look at your patients, look at who you're seeing, and filling these rosters out the way we have them so that we can get them loaded in so then you do start getting these discharge notifications from us. With these things, with the discharge notifications, a lot of you are already getting discharge notifications from Healthy Connections. But with the list that we get you, we're sending you these discharge notifications on those patients you've recognized that are being seen or assigned to you. And it gives you a little bit more additional information. So you're not going through a ton of different discharge notifications to find which ones are useful and which ones are not. We're helping you identify those and send those report to you. We will develop the MCCM fact sheet. We will get that. We do have a social detriment of health screening that we do use. You may have something similar that you're already using, but if you don't, we do have a template for you to use. We will develop the MTCM and MCCM billing platforms so that you can fill these out and that we can make sure that you're getting reimbursed. And then also set up meetings with you over the next 3 months, just to follow through, find out where you're having friction points, seeing what we can do to help you identify best practices, other methodologies that could help you improve how you're doing on MTCCMs and CCMs. Now, with the clinical partners, one of the key facts is identifying before you actually, for those that have not started the process, or even those who are still in the process, is who should be involved in the process, who's going to be relevant to help you meet these measures with the MTCCMs, CCMs, and helping to close these care gaps. So you don't want people that are not going to be able to book appointments, not going to be able to provide care, or vice versa. You want to make sure you have a good, healthy mix of who's involved, who can really make this process work. Again, completing the roster templates and order forms and getting them back to us by August 1st. And like I said, please try to make them as accurate as you can. The more information you give us with what patients that are assigned to you that you are seeing and following up with, the better we can get this stuff into Healthy Connections so we can get you the right discharge notifications in a timely manner as quickly as you can. And that's the other thing, is making sure you identify how often do you want to get these. Is it once a day? Is it real time? The moment we get it, you get it, and how you want it sent. And then the other biggest thing is start looking at how you're going to implement MTCM, how you're going to implement doing the social determinant screening, and begin starting to use those and get used to those. It is a change in a lot of people's workflows. So it's one of those things you want to work with, train with it so that they get used to and they start getting comfortable by October 1st. And with that, I will turn it back over to Joanna.
Thanks, Ian. Appreciate it. So I don't believe any questions came in through the chat, and I don't believe anyone raised their hands. Definitely now is a time to ask some questions, also to voice any thoughts, other ideas that you have with working towards some of these goals, any anticipated barriers that you have. It's no surprise to us that we know that there's significant workforce shortages and concerns in the region with healthcare. We understand that this work will in some ways create some additional work. However, it does build on the foundation of the work that you're already doing as part of the value-based world and patient-centered medical home. And it will funnel additional funds to your organization to do that work. So we do believe that is a huge opportunity within this grant for the region to reimburse you for some care that you may already be providing in some form or another, but you're not getting reimbursed for it because it's a Medicaid patient, let's say, and that doesn't reimburse for TCM or CCM. This will allow you to keep doing those MTCMs, but now you'll also get to start doing MCCMs. So we're excited about this opportunity for the region. I do see Adrian put a comment in the chat. If a TCM or CCM is sent to our practice and the patient is not currently an established patient, how have others addressed those patients? That's a great question, Adrian. And it points to one of the sort of realities of value-based care that particularly among the Medicaid population, they are assigned to someone, whether they're engaged with a practice or not. So I guess on a high level, we would say do what you can with the patients that you can. If they're not an established patient, but they were somewhat recently discharged from your practice, we have seen that other partners have been willing to retry reestablishing a relationship with that patient and using that TCM or CCM opportunity to do that. If they've never been your patient, then there is an opportunity to, staffing willing and available, use the information that the payer provides to try and call or mail to the patient to try and work with them to get them in. We understand that you can't get them all. We get it. You can't. There are some patients you could call and you will not reach them. Our goal is to be reasonable. So we would expect that a fair portion of your TCM and CCM patients will be known to you, will be reachable, and you'll be able to at least attempt to work with them. That having been said, I don't know if there's any other perspectives on the call, if you would want to address Adrian's question and how you handle that within your practice. Or if Heather or Tracy, Ian, if you would have anything you'd want to add to that.
I think, it's important to know that if you're receiving these alerts, the patient is somehow tied to you. And we all know, especially with the Medicaid population, that a lot of patients are often auto-assigned. If you have tried to reach out to the patient and you can't get a hold of them, at that point, you really want to look to your United Healthcare or your Fidelis representatives to try to get that person off of, your roster, and hopefully they are being seen someplace else. A lot of times patients will just be auto-assigned and have no idea that that's who they're assigned to. So if everything fails and you're still getting a lot of discharge notifications, definitely reach out to their insurance provider.
Thanks, Heather.
Yeah.
And I see Sue Perry put in a comment that you use of service outside of your practice for CCM, and does that exclude MCCM for us? I'm really glad you brought that up, Sue, because that was something that our team was thinking through. And what Sue's referring to is that some of you utilize a third-party vendor to conduct some or all of your chronic care management. These are companies like Care Harmony, Signal Lamp. There's several others nationally that do this as well. It's a great tool to be able to conduct chronic care management for your population if you have limited staffing resources. And some of our partners even use a hybrid approach where you use the vendor for a big chunk of your CCM, but then you have in-house care managers that can take on certain cases and certain patients. Short answer is, I don't believe that would exclude MCCM for you, Sue, and any others who would try to use this. As Tracy mentioned, we will put together an MCCM fact sheet, which is basically if NCI or the HRSA grant is going to pay for the chronic care management for your Medicaid patients, what will be required? And Tracy kind of described a little bit that we do want it to align with the Medicare fact sheet for CCM. And that's what your vendors would be used to. There will be a couple of differences though. And I think the biggest one is we would require a social determinant of health screening to be completed as part of a chronic care management service for the MCCM. We would not expect the full-blown standardized tool to be done every single time that you meet with a patient for CCM, because we know that you're going to potentially meet with them as often as monthly or more. But really the intent is more to do an initial one when you first establish that patient in MCCM. And then as you move forward, are there updates to the patient's needs? However you ascertain or, however you get to that with the patient. So the real question is, would your vendor be willing to conduct a standardized SDH screening? And Sue, you might not know the answer right off the bat for that, but that might be something to reach out to your vendor to see. You have the SDH tool that we use for MTCM. It would be that same tool would be the one that we would see if they could use. If they can't do it, if someone on your team can separately do it with the patient, that would be acceptable as well. Anything else you'd add to that, Heather, Ian, Tracy? Good question, Sue. Thank you. What other questions does the group have? Okay, Sue says, I know it would cost more than $60 for our vendor to do just a social determinant of health screening tool. Okay, interesting. Yeah, and we don't have, we know a little bit about what the vendors do. We know there's cost sharing. I'm sure like you bill for the CCM, and you get paid by Medicare or whomever, but then I'm sure there's some kind of way that you're paying the vendor for a portion of it. So the fact that if you think it would cost more than $60 just to do the SDH, that obviously would not be financially solvent. So then is there a way to somehow accomplish that screening? Again, the initial screening is going to be key, but could they do that? Could one of your team members somehow separately do that with the patient in some fashion? Would be what we'd want to look to do. What other questions or thoughts does everyone have? And because this is the first that you're hearing about it, you're probably just digesting some of this. So please know that if you, as you're thinking about this, if you have questions before our next regularly scheduled meetings with you, please reach out to your practice transformation specialist that you see on the call here or myself. We can start talking this through with you. I will reiterate that we will send the slides and the recording of this session to all of the people that we invited to this, because we know that some partners couldn't make it to one of the sessions. We held a session yesterday. It was identical to this, so you didn't miss anything. And then we'll just start working with you. We can work with you individually on an organization level to start sending out, like Ian mentioned, those patient roster templates, the order form, et cetera, and kind of we'll work with you individually to get this work started over the next few weeks. So any other questions though? I'll pause one more time. And Jessica Jones asked, are there any plans to conduct partner meetings so we can share directly with each other? Yes, we can absolutely do that. Our goal is to facilitate best use of meeting time. So we were thinking of, like, we could have set up a completely separate, like, recurring quarterly HRSA meeting that, again, bringing all of you onto this kind of same platform where we talk and go over it. We can do that if partners are interested in that. Our thought was that partners might prefer just using our regularly scheduled partner meetings to accomplish HRSA related stuff. So we're not adding another meeting on your calendar, but it sounds like there's some interest, and we could do both. We could essentially still go over HRSA every time we meet with you, but we could establish something where you can share best practices. And I do love that idea. And it sounds like Adrian also has chimed in. Great idea with that as well. So just a quick poll, I guess, if you want to, I don't know, raise your hand or put in the chat, but any other thoughts or interest in if we had some type of regular HRSA specific partner meeting to share best practices? And our team we can take that back and we can think through an approach for that. And again, it wouldn't envision making it mandatory, but it would be more about whoever would like to join to share directly. We can make that happen. Anything else? All right. With that, you see our information on the screen. You're probably already aware of it anyway, but that's how you can get a hold of us. Thank you so much for joining this call. And again, we will be reaching out to you with additional information and with the slides and the recording. So thanks, everyone. We look forward to this work together. Have a great day.
Thank you.
Thanks.